Okay. Okay, well, good afternoon. We've just gone 1 o'clock, so I think it might be a good point to kick off this webinar on evaluation of the Patient Care Race Equality Framework. So this is a webinar hosted by the Mental Health Implementation Network, which is funded by the NIHR. My name is Jade Asminchi. I'm a clinical reader at King's College London and an honorary consultant psychiatrist with South London Maudsley Trust. And within this context, I'm the project lead for this project, which is about evaluating the Patient Care Race Equality Framework. I'm going to be co-chairing this event with my colleague, Jason. I don't know if you can introduce yourself, Jason.
Yeah, sure. Good afternoon, everyone. My name's Jason Grant Rolls, and I'm one of the lived experience leads for the Mental Health Implementation Network.
Great. And so we're going to be taking you through this event over the next 2 hours. Before we kick off, I wanted to first share some housekeeping slides. So this is a webinar, and so what that means is that delegates will be muted throughout the event. We have a Q&A function, which you'll be able to use where you can ask us questions. If you do use it and you want to direct your questions towards any of the speakers, just at them in the Q&A function, and then people might be able to respond to you. We'll have a very, very short slot at the end when we may be able to pick up more general questions and answers, but we'll keep an eye on that. This event is being recorded, so if you need it, please enable captions. And if you experience any technical issues, my colleague Michelle Harris-Taffrey from ARC South London is on hand to help, and there's her email address if you need to contact her. And we're also going to be tweeting about the event, so please do use our Twitter handle, #MHIN. Okay, so before we start, we just thought we would take you through the agenda. So Jason and I will provide an overview to the session today and provide a little bit of context on what the Mental Health Implementation Network program is, as well as a little bit of a background as to why we're here today. And then we'll move on to a lineup of excellent speakers. So we'll hear from Jackie Dyer, providing a national perspective on the Patient Care Race Equality Framework, and then move on to hear from our MHIN partners in Yorkshire and Humber, as well as Greater Manchester, to hear about how they've been going about evaluating the Patient Care Race Equality Framework. We'll have a very short break, 10 minutes, and then we'll come back to hear from a peak ref team in South London Maudsley Trust to hear about their experiences of implementation. We'll then have a very brief 5-minute Q&A session, and then we'll wrap up and conclude. So I'm now going to hand over to Jason to tell you a little bit about why we're here today.
Yes, thank you, Jay. So as I said before, I'm one of the lived experience leads for the MHIN program. And I guess for me, thinking about the reason why we're here, really, for me, it's a really personal endeavor. So I was diagnosed with a severe mental illness when I was 35. And I guess before that time, mental health wasn't really a conversation that was had within my kind of family or wider friend circle. And I think we were really experienced the kind of negative impact of poor mental health, but we didn't really understand how to get kind of access and support for effective treatment. I think one of the things that really kind of I was really kind of alive to really is once I kind of was able to make sense of my own personal experience, I was really determined to try and use that experience to help others. So I've essentially been doing that for the past 10 years or so now, working within systems, so within civil service, within kind of the NHS, and within kind of academic endeavors to really try and make sure that we are improving access for people across the whole country. So we're hoping today that this will be a real showcase of the work that's been achieved locally, regionally, and nationally, and kind of working towards the change that we want to create and that we all want to see, really. So I think that's enough from me. I'll hand back to you, Jay.
Great, thanks. Thanks so much, Jason, for providing that perspective. Let me just take the camera off so you can see me. So I'm going to now provide a bit of backdrop or background to the Mental Health Implementation Network, just really setting out what it is. So we're basically one of 7 priority networks funded by the NIHR. Our network is obviously focused on mental health, and we're led out of South London and east of England, which are hashed on the map there. But you'll see that we're essentially a consortium of people with lived experience, voluntary organisations, clinicians, implementers, and many other partnerships, including applied health science networks, health improvement networks, or health innovation networks, and national partners as well, really with a view to addressing this care gap in mental health. So there's a sort of 17-year gap between identifying evidence and then getting that evidence to work for patient benefit. And the network's all about trying to speed that up and just speeding up that slow translation from evidence to practice, as well as tackling the issues around uneven implementation and with a focus on underserved populations and conditions. So we're going to hear today, particularly from our partners in Greater Manchester and Yorkshire and Humber, about the work that they've done as they've come on board and joined the network in terms of the evaluation that they've been doing with implementation. So when we first started, which was probably around about back in 2020, we started off with a fairly comprehensive prioritization process to really try and figure out what do we need to do, which areas do we need to be focusing in on. And this was underpinned by a series of, by a systematic review, which was then followed up with a survey and some work to identify common themes and priorities, followed by an expert opinion survey and a decision-making workshop. And if you're interested in the methods that we used and our findings, there's a QR code there on the screen. If you scan your camera to it, it'll take you to the paper that came out of this work. And what we found when we did this detailed prioritization, we came to identify 3 specific topic areas or priority areas that we've moved forward with in the next phase. And the first priority area that you can see there, improving access and outcomes in mental health services for racially minoritized communities, is the one that we're here to talk about today. But you'll see that we also did some work to prioritize and identify that work needed to happen for children and young people's mental health, as well as integrated care for substance use and mental and physical care. But we're here to talk about that first priority area today. Okay. So following identifying the priority areas, we did some more work to prioritize the sorts of interventions that we would want to evaluate under MHIN. And this was another process that involved consultations with experts and working with our AHSN partners to think about implementability. And we ended up prioritizing interventions for each of those topic areas according to these criteria that you can see here. So the patient care race equality framework came out the strongest because it met all of these criteria over and above all of the other interventions that we at the time scoped out. Okay. So the patient and carer race equality framework really came at a really important time. There'd been a 2018 Mental Health Act review, which had highlighted really stark inequities. It highlighted that Black and other racially minoritized groups were more likely to come into care under coercive and involuntary pathways, and at the same time, much less likely to get good care. And so this is an ambitious framework that came out of that review. And at the time of us starting this work, there were a couple of sites across the country who'd already started to do this work. So pilot and early adopter sites. And we put out an expression of interest and had a process where we sought partnerships with collaborations working on this area. And we ended up appointing two ARC partners, applied research collaboration partners, to work with us in the MHIN to evaluate how the implementation of the patient care race equality framework was happening in their sites. And so the two partners that we identified and who are going to hear hear their work today were Yorkshire and Humber and Greater Manchester. And you'll see that they've taken slightly different approaches to how they're evaluating what's happening at their local sites. And I guess part of this is, really trying to learn from what they're finding, but then also drawing together shared learning that can help us to think about how to do things better as we move forward. Okay, so I'm gonna just stop there, and I'm hoping our next speaker is with us.
Yeah, Jay, I can see that Jackie's in the in the participant list.
Oh, okay, but not.
I don't know if she can hear us, Jackie.
So, Jackie, we can't see you on our list. I'm wondering if Michelle or could maybe help.
I've just asked Jackie to come into the panelist area.
Okay.
So should be
Great, so we'll wait for Jackie to join us.
Hello.
Hi, Jackie, you made it. Good to see you. So Jackie, I'm very pleased to see you. So delighted to introduce you to Jackie Dyer, who is Councillor Jackie Dyer, who's been passionate advocate for the patient care race equality framework. It's really nice to have you here with us. And Jackie's going to provide an overview and a national perspective on the patient care race equality framework. So thank you very much. I'll hand over to you.
Thank you. I'm just trying to see if I can see the, yes, I can see the presentation. Good afternoon, everybody. 1 second, I've got my window open and I don't want to have that distract me. And what time have I got? 15 minutes. 15 minutes?
Yeah, you've got until 1:35.
Okay,
I'll give you a warning if you're running over.
That would be helpful. Yeah, that would be helpful. I really want to aim not to run over. So my name's Jackie Dyer, and I'm the Mental Health Equalities Advisor for NHS England, a lived expert by experience, and the chair of the Advancing Mental Health Equalities Task Force, the strategy of which within sits the development of the Patient and Carer Race Equality Framework. And that is a co-produced, has many members, the steering group that has led to the co-production of this framework. And it's the first anti-racism framework for mental health in the NHS. Next slide, please. So we'll canter through this because we've got 20 minutes. And so the next slide, please. So a little bit about me. As I said, I'm a lived expert by experience. And the reason why I'm so driven in terms of improving mental health service provision, particularly for any communities that experience the worst disparities of mental health service provision and experience discrimination, oppression, or racism, is primarily because of the experience of my own family. I have 3 siblings, or had 3 siblings, who experienced severe mental illness from their late teens. So over 30 odd years, perhaps nearly 40 years, I've been a carer of siblings with these challenges and have experienced firsthand the disappointment of services that have not really met their needs. My two younger brothers, Barry and Carlton, Barry died at the age of 53, 6 days after George Floyd died, and my younger brother died, my baby brother died at the age of 41. And for me, this is a stark indicator of mental health service provision that has not met their needs, not met the needs of our family, and indeed not met the needs of other families or community members. And we know a whole range of stories that illustrate this point. And more recently, I lost my aunt who died whilst in the care of mental health service provision. And so for me, the whole agenda is absolutely urgent because I don't want to have happen to other families, to other communities, what happened in my own life, in my own family. And for me, it's absolutely urgent. And I've got a sister who's still alive, and every day I'm always anxious about, is she going to stay alive? You know, at what point do services really meet her needs? And if it weren't for the support even of our family, she wouldn't be here today. And it's just scandalous that the public purse is being spent in a way that's not meeting people's needs when they're at their most vulnerable. And what that means when we talk about racialized communities is where the experiences are the worst. Next slide, please. So the evolution of the PCREF, well, it was an idea that arose in my mind when I was aware of the workforce race equality standard. And I used to say to myself, how comes we haven't got the equivalent of that for actually the patients and carers, those that are actually receiving the services? How can that be? And quite rightly, we pay attention to the workforce, but the purpose of the workforce is to meet the needs of patients and carers when they're experiencing mental health challenges. And the feedback that must emerge from patients and carers must be indeed the most valuable feedback that any service could receive in order to ensure that their service provision is really responding to the needs of the communities that they serve. And so it was with that idea in mind that I proposed this recommendation within the Cruz Commission, and as the vice chair of the Mental Health Task Force for England's Mental Health Task Force, I was able to promote that also in the 5-year forward review for mental health. And that didn't gain much traction because of resource implications, I imagine. But when the independent review of the Mental Health Act came about, I knew that that was a place where I could surface this particular recommendation. And indeed it was so. And as co-chair of the African and Caribbean group of the Mental Health Act review, we were able to prioritize that recommendation for the development of the PCREF and also for culturally appropriate advocacy, which was able to be taken ahead of the wider work that needed to be done on the development of the Mental Health Act white paper. So NHS England agreed to take forward the PCREF in 2019. We brought on board CQC and EHRC. As I said, it's a co-produced framework, essentially a race equity accountability framework, and as I've said, an anti-racism framework, and working with service users, carers, different mental health policy leads from NHS England, as well as other stakeholders such as the VCSE sector. And then we were joined as well with 4 pilot trusts that were really instrumental to helping us to shape in real life what the PCREF needed to look like. And further, we had early adopter sites that joined on board to further strengthen the development of what essentially is guidance around implementing the PCREF. And we launched the draft of that in 2022, and then we were able to formally launch the PCREF, the Patient and Care Rated Quality Framework in October 2023. And then, because it is a very much a systematic approach, it's located, for example, in NHS standards contract. Next slide, please. So what makes the PCREF stand out? It's a very rigorous, systematic and transparent approach. And its key ingredients are that it is very much a participatory approach. And when we mean participatory approach, we're saying that all stakeholders, including communities, patients, carers, the workforce, leadership, VCSE sector, all are part of the people that need to be involved in order to help shape the implementation of the PCREF. And right at the center of that, as the name is a clue, are patients and carers and racialized communities. It's also present within the NHS England's Health Inequalities legal statement. As I said, it's in the NHS standard contract and will be mandatory from April 2024, next month. And we've integrated it into the CQC mental health inspection processes. So in this first year of the CQC, of the rollout of the mandatory nature of the PCREF, the CQC will be supporting mental health service provision to pay attention to the PCREF, but won't be incorporating it into their judgments until the following year. So this year is a supportive role that they will play. It's part of the NHS England's EDS system, part of the SMI and physical health, is part of Core 20 plus 5. We've got support from social work and ADAS, as well as the EHRC in terms of the public sector equality duty, and statutory and voluntary and community sectors. And I think it's important to remember that the PCREF applies to wherever the public purse is spent on mental health service provision. So it applies way above and beyond statutory mental health service provision. Next slide, please. And so to the PCREF itself, the shape and form of the guidance of the framework, it's in 3 parts. Part 1 is about leadership and governance, and that's about making sure that there is accountability at every level of any hierarchy that's providing mental health service provision. So from the perspective of a mental health trust, there must be a nominated executive board lead. And the responsibility around leadership and governance means that there needs to be a co-produced, co-developed action plan in relation to the implementation of the PCREF. So that's about leadership and governance. And that action plan would incorporate part 1, part 2, and part 3. Part 1 also is the collation of data. And that's like the collective evidence, data intelligence of actually data that's already collected, but pulled together in a way that enables the participants of the participatory approach of the PCREF to be able to look at that intelligence of quantitative and qualitative data, i.e. the implementation of the Mental Health Act through the lens of ethnicity. We do that. We collect data in terms of equality protected characteristics. So we can look at the Mental Health Act in terms of section 135, 136, 2345, 20, in terms of that ethnicity lens and gender and age, and the Use of Force Act, restricted practice, feedback from culturally appropriate advocacy, population health data. There's a range of data that's collected in part 1 that acts as intelligence to inform what takes place and the conversations that take place within part 2 of the framework, which is around national organizational competencies. Part 3 is the patient and carer feedback mechanism. That's a combination of 2 key things. One is patient-related outcome measures, and The other is what we're developing, which is a real-time digital feedback tool to identify from patients, carers, and communities the reality of their racialized experience and whether or not they're experiencing discrimination, systemic racism in their encounters with mental health service provision, so that that more real-time feedback can be given to professionals, to teams, to services, and to the wider organization. But if you think of part one and part three of essential sources of data that then go into part two. And part two is where it's like the engine room. So using the organizational competencies of cultural awareness, core learning, staff knowledge and awareness, partnership working, co-production, and paying attention to the workforce, one takes the intelligence from part one and part three and uses those organizational competencies to change the trajectory of what the data is saying in part one and part three. And the action plan that is derived from thinking through what does this mean for, what do these organizational competencies using this data mean for children and young people services, inpatient services, secure services, psychological therapies, community mental health services. So in application, right, of the PCREF to each of those service areas, one might imagine different partnerships might arise in terms of service innovation or service transformation to attend to the particular problems that have been identified through an analysis of the data that's emerging from part one and three. But that data analysis is taking place not just through experts in data analysis, but the expertise that is located with patients and carers, workforce, leadership, communities, and the VCSE sector in conversations and negotiating what of the organizational competencies need to apply in order to change the trajectory of that data. So one can see that it's an interdependent, very robust and rigorous systematic approach, which actually yields information that will be incorporated into a dashboard. So we're creating a dashboard to make all of this data visible and transparent, because we want to move from services that are experienced as untrustworthy to services that are experienced as trusting, because they are able to share what progress they are making, what actions they are taking on improving access, experience, and outcomes for racialized communities. And that dashboard will be present at a local, an ICS level, a regional level, and a national level, populating part one, the evidence in part one, the evidence in part two, and the evidence in part three, of paying focused attention to this agenda. Next slide, please. So we can see here some of the data that we're actually now really attending to. So I mentioned before that you can look at Mental Health Act data by ethnicity. And in this particular slide, you will see that more people are likely to be detained under the Act if they're particularly from Black backgrounds. They're more likely to enter the system, mental health system, through criminal justice route, and likely to be detained in hospital for longer. So if you look here, this is a national data, looking at the data, but you can look at it in terms of a local geography, a trust geography, a regional geography, an ICS geography. And what you will see is that Black communities make up less than 3-4% of the national population. But here they experience the most restrictive intervention in terms of the implementation of the Mental Health Act. So community treatment orders, you make up about 4% of the population, but across the country, you're nearly quarter of the population experiences community treatment orders. 21.9% of the total population of people detained under the Mental Health Act who are under CTOs are from Black communities, and yet they make up less than 5% of the population. So in having this information, made transparent, one has an opportunity to attend to the reality of how racism manifests itself, because there is an othering that is taking place. The idea that is present in terms of stereotypes about the Black body as being big, black, and dangerous is actually very present, played out in the disparities experienced in terms of mental health service provision, the implementation of the Act. Next slide, please. And a similar characterization is played out here. Next slide, please. And another interesting feature is when you look at restrictive interventions by ethnicity, and you can see that there's a massive rise. There's always been a disparity here of higher levels of restrictive interventions by ethnicity, particularly for Black or Black British communities, but a stark increase in from 2018 up to 2022 is very apparent when you look at these this graph. And the introduction of the Use of Force Act hopefully will help us to further attend to this matter. Next slide, please. And that Use of Force Act data is present in part 1 of the PCREF framework. So some of the next steps and priorities for the ongoing development of the PCREF. So we're in version 1 of the guidance, and clearly this is a collaborative effort across the country. So we've got our pilot sites, we've got early adopter sites who are constantly coming through. So those are in ever increasing numbers. So it's a national community of practice essentially that is in evolution here, as all hands are on deck to improve the racialized experience of mental health service provision. So that role of doing that from an ICS and ICB level is actually really critical. So we want to support the ICSs and the ICBs about what role are you playing in both making this agenda visible, but also pulling together in your patch what that data says at the next level in terms of the geography beyond the local mental health service provision. And then what does that say that you need to attend to through your partnerships and the work that it is that you do in order to support the journey of transforming access, experience, and outcomes for racialized communities. And indeed, what does that mean for that interface between primary care and secondary care? Because surely actually looking at what happens in secondary care gives you some illustration of what is needed to get done at much earlier down the pipeline to actually prevent the sort of almost automatic pipeline of people coming in crisis when from racialized communities and getting poor outcomes. Surely we can intervene earlier if we understand that the worst outcomes are actually manifesting because people are avoiding services because of their fear of dying when they're in that care. But actually, also, it's really important that the quality of the care when people are in crisis is at its utmost best, that it is of the caliber and excellence that is warranted for people when they lose their liberty and are that vulnerable that they are utterly dependent on the expertise of those involved in their care. And furthermore, we want to pay proper attention to those other experts that are involved in the care of people who with severe and enduring mental health challenges, and those are carers. So we really want to strengthen the role of the PCREF in relation to carers. And as I said, we'll be developing the transparency, the data, the PCREF data dashboard, because we're moving away from closed culture to open culture so that everybody can see, everybody can be involved if they need to be involved. And actually, that collective effort around the collective intelligence, it inspires collective action that helps us to be more responsive and get in the right direction of changing the trajectory of experiences from one which is wholly negative and in some cases far too many fatal. And continuing to support trust around all their service pathways and sectors. And indeed, we will also be evaluating the implementation and the impact of the PCREF as we continue this journey. Next slide, please.
One more minute, Jackie. We just have
Yes.
time.
So this is basically, you know, how can you get involved? Next slide, please. And just so that you know where you can access resources to get familiar with the work that's being conducted. These are the details, and I'm sure you'll get them in the pack. Much of our resources are located on the NHS Future Collaboration site. And one final thing is that we'll be doing a series of video podcasts to unpack the PCREF that will be open to everybody. But primarily, we want to be able to engage with our communities and our patients and carers so that they understand this significant opportunity and how to get involved to support mental health service provision, to do the transformation and innovation that is involved in this endeavour. Thank you very much for your time.
Thank you very much, Jackie. Real tour de force, and really pleased to see that you're involved in this work. And we now move into the speakers from our site. So Scott, can I? Yeah, you're here there, Scott. Nice to see you.
Hi, Jason. Thank you so much. So I'm Scott Weish. I'm Professor of Mental Health in Sheffield, and I'm very involved in ARC. So I'm co-theme lead for our mental health and multimorbidity theme, Yorkshire Humber, and I've also been a member of the MHIN exec representing ARCs around the country. So I'm going to talk about our evaluation of PCREF in Sheffield. Can I have the next slide, please? Thanks. And then maybe the one after that. Great, thanks. So what I'm going to reflect on today is about trying to undertake an evaluation of a very complex intervention. And it isn't an intervention. It's a framework. I mean, we've heard that really inspiring presentation by Jackie that explains where this came from, what it wants to achieve, how it intends to go about it. And it's a series of kind of guidances and requirements of NHS trusts, but it isn't one thing. And so it's going to be sort of picked up and used differently in different places. And I'm going to just reflect a little bit today about how we've gone about trying to evaluate what's happening on the ground in Sheffield. And Sheffield is an early adopter site, which means wasn't in the first group of trusts, but it's amongst the enthusiasts. And we were commissioned to undertake this evaluation. And what I'm going to present today is on behalf of not only myself, but also our small research team, led by Donna Franklin, our excellent researcher, and two of our colleagues from the Yorkshire Improvement Academy, Zanira Khurshid and Vishal Sharma, who have been our great allies in this. And then I'll show you the wider project team at the end. What I'm going to say is a little bit about what we're doing in terms of the evaluation, but also some reflections along the way. And what I would reflect on is that there are many reasons to think that PCREF won't succeed. This is one of a long history. I've been involved in some of these, long history of really well-intentioned, really carefully thought through approaches to trying to address what is, as Jackie says, one of the worst, most intractable, most awful problems that we face in mental health care, the ethnic inequalities that she outlined. And what tends to happen in the NHS is that these are led by very inspirational people like Jackie, who have, great energy and commitment and get, with a lot of work, get things up and running, which then have some impact, attracts a group of kind of supporters, but then it runs out of steam because the NHS has so many things to worry about, and the priority sort of moves on to something else. And these sorts of things sort of fade into sort of history. So what we wanted to learn about in doing this evaluation was what's happening on the ground for two reasons. One, so that we could really sort of uncover what was working well and the theories and the kind of processes by which change is achieved, but also so that by putting a spotlight on this, that we could support sustainability. Because I know full well that in 5 years' time, it's likely people will be talking about something else. And we have to make sure that PCREF stays on the agenda. So we've approached this from the point of view of wanting to evaluate, wanting to find out how it's really working, kind of taking it apart and looking at the kind of inner workings of PCREF in a real world setting. So we have these 5 work packages, and we're calling it a mixed methods realist evaluation. We start off by looking at who's involved and how. We have tried to look at the logic model, which is which incorporates the sort of change theories that the people delivering this have faith in, believe in, and which motivates the processes that they've set in place. We will then go on to look at what's really changing on the ground and looking at the kind of barriers, the successes, the sort of difficulties when implementation is underway. We'll look at, you know, how good locally the trust is at generating the sort of information that Jackie is very clear needs to be sort of fed upwards. And then we'll come back and sort of ask kind of key participants to reflect on the initial logic model in the light of their implementation experience and tell us what didn't pan out in the way they expected. So if I could have next slide, please. So just to say that, you know, this is the trust's quality set of objectives. And my reflection of this is that where PCREF is going to work well, it's going to be pushing at an open door. You know, things in the NHS these sorts of initiatives tend to work well where they incentivize and resource things that an organization already wants to do. And so with that in mind, I would say that it's actually quite difficult to tell when PCREF began in Sheffield. Next slide. Now, this gives you some idea of this, that work was already underway because people were coming together and having conversations and wanting to make a difference and knowing that things weren't right. So long before, or some time before PCREF launched, and, you know, when it launched is you know, a kind of question I probably couldn't sort of answer. But these conversations, these partnerships, these dialogues, these trying to kind of build trust activities were well underway. And PCREF became, therefore, an accelerant, became a catalyst for this, and continues to be so. Next slide. Just to mention something about involving people with lived experience. Traditionally in research, we go out and we recruit a lived experience panel, and we were asked not to do that because the people running the PCREF locally felt that it was already embedded enough in kind of lived experience, and that wouldn't add any value. And I would reflect further, one of the challenges of doing this kind of evaluation is building the trust of the people that are being evaluated, if you like. We have to be on side with them, we have to be independent and objective, but we have to also make sure that they trust us. So at first, when we said, you know, guys, great news, we've been given this money to evaluate PCREF, there was a sort of silence and, you know, tumbleweed moment. And there was a moment at which it felt like that might be very inhibiting to the PCREF program locally, that actually we would be sort of putting a spotlight on, we would be looking at them under the microscope, and we might somehow be kind of funded to tell them things that weren't very helpful. And so we've had to do this in partnership with the PCREF team, with the leaders, with the people behind it. And so we've tried to walk this tightrope of sort of listening to and telling their story and kind of, you know, telling the sort of narrative of how they've got here, but also trying to at times to sort of stand back a bit. And that isn't always tremendously easy. We are involving lived experience experts as peer researchers, and we're building on a local scheme that was actually set up through the, some people will know about this, the Deep End initiative in primary care research, which was about trying to engage and work with unheard and sort of hard to reach communities. And so one of our community partners in Sheffield has this scheme that they run with the Deep End project of community research link workers, and we've recruited two to work with us, and they'll be mostly involved in work package 3. Next slide. Just to highlight one of the important sort of initiatives, I'll come to this in the logic model, but when we looked at things that were actually happening, which had happened as a result of PCREF and that wouldn't have happened otherwise, the race equality lead role was a key one. And this was someone from a community partner who has a very, very specific role in terms of monitoring, responding to, you know, liaising and being part of the sort of trust kind of organization around restrictive practice incidents. And it's a really important role. I'll come back to that in a moment. Next slide, please. So in our first work package, we wanted to know more about who was involved and how. We've called it the relative parties mapping rather than stakeholders, and there is a bit of an academic debate around the term stakeholder, which we are trying to kind of navigate around, but essentially those who have an interest in and an involvement in this. Don undertook qualitative interviews with other partners. We used a snowballing methodology, and we were interested in trying to generate a map. The next slide, please, which looks something like this. And in its first iteration. And it's this two axes. One is engagement and the other is influence, essentially. So, you know, at the top right-hand corner, we've used as a sort of anchor the executive lead for PCREF in the trust. The top right-hand corner shows the person who's most engaged and most involved, because it's her responsibility to deliver this. And we've tried to position people in different places according to the sort of interview findings, and to some extent where people self-identify, but not wholly. I think this map is illustrative that we have, you know, it shows you sort of something of where people are distributed. I think it's not quite right yet. And one of the sort of challenges in Sheffield PCREF that we've discovered is that there are two community partners that are essential and central to and drive this, and we're part of early conversations. Many of the other community organizations aren't fully engaged yet. So I think there will be discontinuities in this map when it's finished, that there will be breaks in that top right-hand corner that show that there's a kind of core group that are very engaged and very involved and very influential, and others that are not quite in that space yet. We've identified a few people that are in that space at the bottom right, which is where people have influence but are not engaged. But we need to sort of iterate this map a little bit. Next slide. And this is what I was saying, that some of the feedback was that there's a small, very committed, very engaged, genuinely passionate, genuinely kind of people who do have their feet in the grassroots, but a small group rather than a wide kind of network of community partners. We did find variable knowledge about PCREF, and again, that's reflecting on the fact that it is, in order to get, and it's a sort of, I suspect it's a two-edged sort of sword, that in order to get that drive and that momentum, it's, you know, required real commitment and real energy from a relatively small number of people who are either employed by or kind of integral to the PCREF project. And that probably reflects a lack of maturity in the program. And generally speaking, we found that there was cautious optimism, even though not everybody knew all about it. And that's good. That's good. Rather than skepticism, there was a kind of optimism there. Next slide, please. So then we went on to try to tease out our logic model. So we had a workshop with the people who are most directly involved, the people who are making decisions, who are responsible for implementation, the people who we will be working with in work package 3. The next slide, please. And that's what our logic is. A bit small there. I apologize, the logic model. So what we've done is we've put outcomes at the far right-hand side, which are the hard outcomes that Jackie mentioned, you know, to do with access, to do with experience, to do with reduction and restriction, to do with better monitoring of protected characteristics and better access to services. And we've looked, because we've heard a lot at the far left-hand corner of this about the resources, about the inputs, about the basic conditions, the work that's gone in over recent years to create this foundation of trust and involvement and honesty and authenticity. And that came across really strongly from the people that we sort of talked to. And in between are the activities. And the activities column, this is one of the things we've had to work really hard on, is teasing out what actually is happening. You know, Jackie talked a lot about governance. Governance is great. And when we talked to the trust initially, they would sort of bombard us with lists of committees that they'd set up. Committees by themselves don't do anything. There have to be activities. There have to be things, like I mentioned, the race equality lead, the race equality officer lead. And we've teased out, you know, 7 or 8 different things that are specific to PCREF that wouldn't happen. Again, we went through the list and crossed off things that were going to happen anyway, things that are specific to PCREF and PCREF only. Outputs are the hypotheses. These are the things, I won't read them out, but these are the things that we ask people, what do you expect to change? What will you be seeing and sensing? You know, and it was more to do with kind of attitudes, beliefs, openness to talk about things, to acknowledge one's own privilege, to be, you know, admitting that the ways that we've practiced in the past haven't always been sort of ideal. We need to see that cultural change if the outcomes of interest are going to change. Next slide. And so we asked a few questions at the focus group, you know, what worked well. And here are some comments and some quotes from people. And I think admittedly, the people we spoke to are the people that are closest to PCREF, so we have to bear that in mind, and we have to have a bit of objectivity. But there was a real feeling, and many of the people there were people who hadn't worked for the trust before, who had been outside of the organization, who felt that they had been excluded, and now have a role because of PCREF. And there was a real energy and belief and passion about what they were doing. Next slide, please. We asked them what surprised them, and there were some really interesting sort of stories that came out, because one of the things that has happened is that there's been an enhanced respect training, which is around restrictive practice and managing clinical incidents. And there was a really interesting story about how staff who turned up for the training, who work on the inpatient wards, had not only been very open and honest about things that had happened, but even to the point of crying about things that they'd witnessed or been involved in. And there was a sort of honesty that I think took even people who, believe that things need to change radically. I think they were surprised at how open people were willing to be. Next slide. And then what's been difficult, and I guess this is talking about just how far there is to go. If really to change the way that people think and the sort of inherent sort of approaches that people bring to their clinical workload. There was a feeling that is still a long way away. Next slide. We are also analysing that data. We've created the logic model, and we sort of revised that and did that in sort of time as people were in the room. But we're also going to be using the transcript from the focus group to be doing some analysis. And REAL is a method that we've chosen. It's supposed to be a rapid qualitative research method. Our colleagues from the Improvement Academy are looking at the data as we speak, and we will hope to be able to generate some early findings to feed back into the implementation program. Next slide. Just a bit about what REAL has to do, but it's the idea is that it's faster and quicker than more traditional analysis methods. Next slide. We've done a documentary analysis, so we asked colleagues in the trust and elsewhere to give us all the documents, everything that they, papers and meetings and agendas and things, all about PCREF, to look at how it, in governance terms, how it was being managed. And we, again, our Improvement Academy colleagues did this work for us. Next slide. And these are just some of the things, they picked out the themes that were very evident in these documents, and how workforce co-production was really important. The governance we've spoken about before, the governance is, had to be front-loaded, absolutely. Next slide. And these are our partners. This is, we see the ARC, the Sheffield Health and Social Care Trust, Improvement Academy, Sheffield Flourish and SACMA are the two main community partners, and they are, very invested in this and fundamental to it. It is very much a partnership with the trust, and that's the list of our very large project team. And I think I'm just about on time, so I'll stop talking there.
Thank you so much, Scott. Wonderful presentation. Can we move across? Oh, yes, I should remind everyone, if you've got any questions for the speakers, please do use the Q&A function, and we'll pick up the questions towards the end of our day today. Can I move on to the Greater Manchester team? Hi.
Hi, hello. Thank you. So I'm just going to start us off with a brief introduction to the implementation of the Patient Care Race Equality Framework at GMMH, and then I'm going to hand over to Juliana, our senior researcher who has led the majority of the work, and she's going to talk you through what we've done. Okay, next slide, please. So just by way of a brief introduction to the implementation of PCREF at GMMH, the implementation has happened and been fed through the Advancing Equity and Inclusion strategy. And that's a key element to the way it's been implemented at GMMH, just thinking about the resources that were required to support it and the governance arrangements that were required to be established. So thinking about that, we do have an executive lead that's responsible for PCREF. We've established an EDI committee, which is a sub-board committee, and also the recommendations around an anti-racism steering group. Thinking about the metrics that are also monitored at both that subcommittee level and also the sub-board level, that has already been implemented as well. So that's that governance and leadership section. Next slide, please. So thinking about part two, which this evaluation is concentrated on, so that community engagement piece that was undertaken to think about those organisational competencies. So part two of the PCREF, those organisational competencies. A series of sounding boards were commissioned with local VCSE organisations, and several things came out of that sounding board that helped to kind of shed some light and understand what those organisational competencies should look like as a reality at GMMH. But one of the key things that came out was one of the assets that was currently evident within Greater Manchester, and this was a mental health collaborative, a Black Asian minority ethnic mental health collaborative that was established during the pandemic. Now, this was very short-term funding that was established through kind of money that was available to support communities in the pandemic. But what became very, very clear in kind of communicating with those VCSE organisations is that what they wanted is that they wanted the support to be able to grow this into a specific fund, specifically to be able for it to kind of be funded and carry on. So what we did is we worked with the mental health VCSE integration lead. That was a secondment from Mind, and we helped to establish the Culturally Appropriate Services Fund, which Juliana will talk about later. And what that did is it kind of, we went through a collaborative commissioning process and commissioned 31 services across a variety of different work streams. And that was looking at VCSE organisations delivering services to their communities. Next slide, please. Just as a really brief background in terms of Greater Manchester and the demographics within Greater Manchester. So there are 10 boroughs within Greater Manchester. GMMH supports and covers 5 of them, and Pennine Foundation Trust cover the other 5. But this slide was just to illustrate the variety of different ethnic groups across all of those different 10 boroughs. So what you can see here is that Manchester has a really kind of high ethnically diverse population, quickly kind of followed by Oldham and then Bolton. And then that changes again with the least kind of ethnically diverse communities within Wigan. And it's really important to make that distinction that it is variable across all the different boroughs. Next slide, please. So thinking specifically about the Culturally Appropriate Services Fund, the fund aimed to do 3 key things. And the first one was to support innovation in how culturally appropriate integrated mental health services could be delivered in partnership with community-led organisations. And this is part of the kind of wider adult community transformation programme. So this was really thinking about not just statutory services, but how could VCSE organisations be real players within that community mental health transformation and look to support their communities, and importantly be funded and supported to support their own communities. And then the second thing was really about developing a partnership model that would enable community-led organisations to, like I say, work alongside and in partnership within those organisations, with the ultimate aim of reducing racial inequalities with respect to access, experience and outcomes across Greater Manchester. Next slide, please. So just getting to the key question. So initially, the kind of key question that we wanted to kind of find out was, to what extent does the Greater Manchester ICB Culturally Appropriate Services Fund provide opportunity to deliver on the Patient Care Race Equality Framework Part 2 organisational competencies? Okay, next slide, please. So what we wanted to look at was the key objectives within the Culturally Appropriate Services Fund set against those national organisational competencies. So we've got 6 national organisational competencies, but it's important to kind of note that through those sounding boards and our engagement with communities, one thing that did come out across Greater Manchester around competencies was thinking about inclusive communication. So really importantly about interpretation services and other ways that we communicate with our communities and our patients and carers. Next slide, please. Okay, I'm going to hand over to Juliana.
So using a framework that we developed, our evaluation was guided by 4 key areas of interest. We looked at the role of partnership working between community-led and NHS services. But more broadly, we examined whether the Culturally Appropriate Services Fund improves service user access, experience, and outcomes. In year one, between November 2022 and October 2023, we employed a quantitative approach and collected survey information on service access frequency and other experiences and outcomes related data. Our approach later expanded into a qualitative one with 7 open-ended interviews with community organizations. I would like to start by discussing quantitative data, and then I will contextualize these figures with the qualitative data. This table shows the number of community organizations that were funded and how much funding went into supporting this work. Service access frequency was measured by the total amount of service users, those who had 2 or more contacts, those who had 6 or more contacts, and we also looked at total contacts overall. As you might notice in this table, of the 3 work streams, core innovation had not only the most service users, but also experienced consistent contact over 6 sessions or more due to delivering long-term interventions. The Culturally Appropriate Services Fund has sowed the foundations of future partnership working between community organizations and NHS providers. Between August 2022 and September 2023, 209 service users were referred to community organizations from NHS services. However, I will later discuss how qualitative findings might complicate these figures a bit. Service user experience was highly valued and captured by community organizations with questionnaires. Service users reported overall satisfaction in staff knowledge and awareness and facilitating ease of access, demonstrating cultural sensitivity, and offering flexibility with service activities. I would like to focus now on the qualitative findings and how PCREF competencies are best exemplified through the work of the community organizations. But I will breeze past these as we have lovely speakers who can speak more to their services. These organizations have built capacious ecosystems rooted in relational infrastructures that enable the delivery of holistic mental and physical health care, but they also tackle social, cultural, and economic inequalities which might stem from embedded histories. Their culturally sensitive interventions are flexible and adapted to the community with support programs like art therapies or multilingual counseling, food fellowships for community building, or support with what is often called integration and adjusting to new cultural norms. These interventions minimize stressors, combat loneliness, and improve mental health in a relational way for their communities. Community organizations are emblematic of delivering inclusive communication, paying particular attention to sensitivity, for instance, using physical health interventions like hiking to introduce discourses on mental health, while chatting side to side rather than face to face. Another example is discussing mental health difficulties through oral storytelling of culturally significant aphorisms or stories. Demonstrating humility is important for service users whose primary language might not be English, as meanings carry significantly more power and resonance in one's preferred language. Ustawi in Swahili, for example, sounds a lot better than wellness. Though it was suggested that representation of service users as race, ethnicity, and cultures amongst staff members facilitated rapport building, it was important for all staff members to be regularly trained. Staff are expected to engage in routine cultural competency training and working with intersectional individuals and families. However, this idea of cultural competency might be best acquired through firsthand knowledge and encounters with other peoples and cultures. As of present, there are significant flaws with referral pathways from the NHS to community organizations. NHS trusts and GPs are aware that community organizations exist, but referrals remain low for some organizations while the demand is high for others. Furthermore, community organizations strive to develop relationships with NHS professionals in local mental health hub meetings. However, this can be challenging when community organizations experience high service demands to make room to network. Community organizations also identify that there's a significant underrepresentation of racialized peoples in NHS decision-making processes. instilling a sense that those who do end up networking experience othering and might feel that they do not belong. Co-production has rooted the innovation driving the Culturally Appropriate Services Fund. Support programs delivered by community organizations are shaped, led, and driven by the needs and equally as important, the desires of service users. Community organizations discuss the value of working with those who have lived experience, known as community champions, as they were seen as further bridging the gap between them and service populations. Moreover, service users also benefited from staff who came from similar ethnic, gendered, lingual, and religious backgrounds as them, in which staff could reflect on their own experiences to understand the intricate nuances of service users' experiences. A key learning point with regards to partnership working was a proposal for NHS governance structures to be subject to due diligence. And as such, thinking about how power of healthcare provision can be redistributed to community-led organizations. Currently, community organizations sustain themselves with funding grants to develop health programs, but this often comes at a cost, with funders being hesitant in providing funding for certain interventions where there's a perceived less value for money. The NHS can embark on this redistribution of power by providing sustained funding for community organizations and for them to determine implementation of that funding themselves. If the trust in particular is to embrace an anti-racist stance and effectively disrupt legacies of colonial logics that continue to configure statutory services today, it unequivocally must confront its elitism in positioning the expertise of its own care provisions over that of community ecosystems. The Culturally Appropriate Services Fund has examined how Part 2 of the Patient and Carers Race Equity Framework can be delivered. Firstly, the Culturally Appropriate Services Fund has established the foundations of future partnership working between the NHS and community organizations, which would flourish in a meaningful and effective way if key concerns from the evaluation are addressed. Secondly, it has enabled innovation within community ecosystems, and many felt that the fund enabled their support programs to expand further. Thirdly, community organizations are actively working towards addressing mental health, physical health, and social inequalities by improving access, experience, and outcomes for racialized peoples. Now, I'm highly honored to introduce two of our guests. Folashade Alonge from Mama Health and Poverty Partnership, and Mel Safari from Lingua GM. Mama Health delivers an ecosystem of care for Black African women and girls in Greater Manchester. Lingua GM also delivers similar interventions, but focuses primarily on supporting asylum seekers and refugees who are based in hotels and pending asylum decisions. I'd like to hand over to Folashade now.
Thank you very much, Juliana. Can you hear me? Right, that's good. Thank you very much for that. Mama Health and Poverty Partnership, we are 10 African women-led organization. We came together to provide support for Black African women across Greater Manchester, addressing health inequality and poverty. So we are one of the recipients of the cultural appropriate funding. And quickly, I'm going to talk about, the journey so far, and also to talk about how this fund has actually enabled us to continue supporting our women. So one of the enablers is the funding has helped to provide salaried roles. So we have, more dedicated time to support the women with the right sessions, and also, the right specialist support that they need, and they're actually engaging well. And also, one big thing for us since we've started providing this support is that the women have better insight into their mental health condition, because we are commissioned to provide specifically culturally sensitive support for women that are living with severe mental health difficulties. So there's more insight to, what they're feeling, and there's a lot of encouragement to get diagnosed. And for those that have been diagnosed, we are providing one-to-one support. We have been able, for the past 18 months, to reach over 70 women, providing one-to-one support through counseling and psychotherapy. And also, we've been able to provide group therapy. Some of the women are a bit shy. They want to kind of get into group before they access one-to-one. And what really have worked really well for us is the psychoeducation sessions, which we call the well-being session, where we talk about the different mental health difficulties, and women are getting to open up and to tell families and friends, and all in effort to normalize their mental health. And we've been able to pull Black African mental health professionals together so that we can draw that support from various conditions to be able to support our women. And the big barriers that we have is cultural, and the cultural practices for immigrants, coming into the UK, and the stigma around mental health in the African community. So we've come a long way, and the journey continues. So we are still trying to keep, helping to get the women to break those myths and the stigma around mental health. And one big issue for us is that we provide holistic approach, but because of intersectional issues such as immigration, poverty, abuse, racism, it's a major challenge for our women to focus on their mental health. So it's like there's a cycle of re-traumatization, because it takes better living condition, poverty, immigration. We support women that are in the asylum. So when we're thinking about women, we're thinking about, levels to privileges, women going through racial difficulty, inequality, gender inequality with multiple disadvantages, immigration, poverty. Yeah, so it takes a change in their condition. So it's a major barrier for us, in terms of like when we're thinking about women that are actually at the bottom pile when it comes to privileges. So it's also been a good working experience with the NHS. We've linked in with GPs. We've referred women to GPs to get proper diagnosis. And also the GPs have referred women to us. We're working with social and focused care workers but we still need support, more support in that area. We want to kind of like, do a bit of more presentation. We could offer them some kind of support. It might be during their lunch break or in their CPD training, for cultural competency training. And also, we think we need help, in terms of the extension of this work, to be able to enable the women to engage, with us and to sustain the support that we have started, because there's a duration to this support. So I think I'll hand over to Mel now to share with us. And thank you very much.
Thanks, Folashade. Just to follow on from my colleagues and introduce myself, I'm Dr. Mel Safari, and I'm one of the co-founders of an organisation in Greater Manchester called Lingua GM. We provide two umbrellas of our core services. We provide direct mental health support to all our diverse communities with no limitation and restriction, and in first language. If we can't provide and offer first language mental health support, we provide that through support of our community interpreting team, who are all either trained or recruited or set up at GM level. So we're not like your big interpreting translation providers where you get somebody who may be based in London and they'll pick up the phone to Sheffield, or they need support in Greater Manchester and they might speak to somebody who's in Leeds. Anybody in terms of our second umbrella of our services, which is community interpreting and linguistic services, all of our linguists are GM postcode registered. So if somebody requests somebody, for example, within our Salford area, they will get an interpreter who is within that mile radius of Salford. So in terms of wider outreach and support, people will get supported by somebody who's familiar with the neighbourhood, the connections, the access to services, and joining the dots with system. As part of the Cultural Appropriate Fund, we've been funded by another partnering organisation called TS4C, and we have been commissioned to provide support and services for all our Afghan evacuees, refugee, asylum seekers across GM. I think one of the things we've really felt that the funding has enabled us to do a little bit more differently, which we've still got work to do, than normal short-term lived period funds that I'm sure you're all aware, things get commissioned, but it's so short-lived that a lot of times projects come to an end, nothing really flourishes, nothing gets set in stone on a long-term sustainability. But one of the things our funding at GM has really supported us, and I hope to say on behalf of other 27 organisations who are commissioned, is we are able to build long-term sustainable connections and relationship, especially with our services, all of us who provide such a specialist niche of support, which is around SMI and mental health and those with severe mental health endurance. Given the diverse populations we support, I think a lot of times, not only, as my colleagues mentioned, the mental health terminology itself is still stigmatizing, and a lot of people have got so much shame and worries attached within specific communities. We still struggle to say to people, oh, this bit of what you talk about, or actually you tick under the SMI criteria of our systems, and they'll go, what? SMI who? What does that mean in terms of me and how I'm being supported? So connecting with Home Office, connecting with Serco team, connecting with our local primary care teams, connecting with our community mental health transformation teams and our Living Well has really worked beautifully for us, for our bilingual refugee asylum seeking residents. But massive challenges around actually in terms of partner and relationship with NHS providers. We're still nowhere near building any connections with likes of our crisis teams, with likes of our community secondary care based teams. So we've got a lot of work to do, but the funding has given us a great opportunity to build some of those long-term connections.
Thank you, Mel. Was there anyone else from Manchester speaking?
It was just very briefly to tie this up and to say that was the first part of our evaluation in looking at PCREF and looking at the Culturally Appropriate Services Fund. And then the next phase that we're going into now is really looking at the extent to which the trust in Greater Manchester are equipped to actually implement the patient care race equality framework. So we've looked inward to the Culturally Appropriate Services Fund. Now we need to take a step back and say, okay, how equipped are the trusts to, one, implement the patient care race equality framework, but two, and importantly, support those community partners to actually be a really big part of that integrated system, that integrated care system. And then just final slide, we will be looking at engaging further, looking at kind of readiness assessments, looking at resources and reflections. And I'll leave it there because I realise the time is running out. Thank you.
Thanks, Kath. Yeah, really lovely to hear the work, especially from the community partners. So we're going to go into a 10-minute break. So if we come back at 2:30, please. And please do keep your questions coming into the Q&A. Seeing a few questions coming in already. So yeah, please do keep them coming. Thanks.
Okay, so we've just gone past, and I suggest we restart for the second half of the program. If people could remember to use the Q&A function to post any questions, and panelists, if you could have a look at the questions, and if they're directed towards you, perhaps have a go at answering, because we're going to have a very short 5-minute slot shortly when we'll be able to pick up a few Q&As, but we won't be able to cover everything. Okay, so for this next presentation, I'm really pleased to welcome Zoe Reid, Shania Ruddock and Annette Davis from the South London Maudsley PCREF team. So SLAM Trust was not one of our original mental health implementation network partners, but have been actually very involved right from the beginning. So I recall that first workshop where your team came and shared some of the insights that you'd started to develop as one of the very early national pilot sites. So looking forward to hearing from you. So I'll hand over to you then, Zoe.
Lovely. Thanks ever so much. And it's great to be here. And my colleagues will introduce themselves as they go through. I'm Zoe Reid, the Joint Strategic Lead here with Dr. Jackie Dyer. So if I can make the technology work. So just to let you know, we don't know how we're going to do it in the time, so we're going to speak very fast. These slides are available for people to look at afterwards. We're going to give you a whistle-stop tour of where we're up to in implementing PCREF locally as one of the pilot sites. But I want everyone to please remember that we're all only at the foothills of all this work. So just a bit of context to the work at South London and Maudsley, and context is really important when you're looking at this PCREF work. critical issue for us was the inequity being a big issue of concern to researchers and everybody else in the area, and everything compounded by the tragic deaths of Sean Rigg and Olaseni Lewis. So this was already an issue for us pre-PCREF, if you like. Just a slide on, just to show you the geography. It's different to Manchester, different to Sheffield. Don't need to go through the detail there. So why is PCREF so important to us, and kind of what's the approach we've taken? So as you can see from the slide, our own data says to us that if you're Black African, Black Caribbean and mixed Black peoples, you're kind of more likely to have poorer access, experience and outcomes. So if you look at our numbers, that, well, certainly in November last year, meant that a quarter of our patients are potentially less likely to receive a quality service. Clearly unacceptable to the trust and to the local community. So what do? We said, well, for us, the PCREF is a partnership approach. And if you're going to have a partnership, you need to know who you're building a partnership with. So we built on our existing relationship with the local Black communities as the basis of our PCREF development. And what excites us really is that the PCREF is the first systematic framework to tackle the conditions holding racism in place and to evaluate effectiveness of our initiatives as we go through them. So my little slot, that was the intro. My little slot is just focusing on governance and processes. As I've said, we took a partnership approach between us and 2 local Black-led host organisations that we were already working with, Lambeth Black Thrive and Croydon BME Forum, and they are supporting local IAGs, independent advisory groups, of which more later. We've evolved what we have eventually called a triple leadership approach, and this basically means that we've got a Black service user or carer rep, a Black community leader, and a senior member of staff, chairing all our groups, leading all our work streams, actively involved equally in all decision making. And we've tried hard to mainstream PCREF as we grow. So we set off in October 2020 with a 2-year work programme, thinking we'd have this done and dusted then. Not a chance. As you know, it's this difficult, complex work, working in a triple partnership, the more rich so. So the good news was that the Trust was developing its strategy at the same time, and so we've aligned our timetable to that, which means that by 2026, the Trust will have embedded PCREF at scale and will be leading anti-racism in mental health. I won't go through this detailed slide. This shows our journey for the first 2 years. The 2023 is in production as we speak, but what I wanted to draw your attention to is the amount of attention to process, to actually working separately with each of the 3 constituencies and bringing it all together. And that remains our ethos, that process is as important as the content. The what is important, and the how is as important as the what. So I mentioned the independent advisory groups. Now, these are groups of committed Black people with lived experience of racism. They've been working with us since back nearly 10 years now as a recommendation from the Lambeth Commission into Black mental health and wellbeing. And their role is to connect the Trust and the local Black communities and VCSs in an ongoing and dynamic way. They're just groups of individuals, fabulous as they are, but they need some charity group support, which is why they're linked into host organisations who can provide much of the necessary infrastructure. So this briefly shows the governance, tries to show the 3 constituencies and how they're organised and working, and then the bottom half of the picture shows them triply leading all our governance. And another way of looking at it, and this is my last slide before I hand over to Shania, you can see this is the current structure. It continues to evolve. This is not the end. It will continue to develop. But perhaps to draw attention in the dotted line, there's something called the PCREF Partnership Development Time. And that's a quarterly meeting when we attend to how are the relationships going, how's the processes going, which is equally important to keep the whole thing on the go. So over to Shania. You say next when you want the next slide, Shania.
Thanks, Zoe. Hi, everyone. So I'm going to be talking about our data and our change ideas and how we plan to evaluate. So next slide, please, Zoe. Okay, so our hypothesis in relation to the PCREF was that we looked at our data, as Zoe mentioned before, and I've identified the 3 main drivers that you can see in the green circles to the left of the screen. And there were also 6 conditions within the waters of systems change. that we identified as holding the problem of racial inequity and racism in place. So our aim was to use the 3 parts of the PCREF that you can see in the 3 yellow circles on your right, to use it as a learning approach to shift towards equity in access, experience, and outcomes. Next slide, please. So as you can see, this is a kind of overview of our developmental evaluation process. So we are using a process that is underpinned by the Proctor framework. But we're also using a Right Now survey to give us an immediate kind of understanding as to where those that are involved with our PCREF change ideas, what they think is happening. And the Proctor framework has 3 areas of outcomes: patient outcomes, service outcomes, and adoption and engagement outcomes. So this will go through a cyclical process every quarter and will be tweaked and amended if necessary. Next slide, please. So here you can see the 6 organizational competencies in the orange boxes at the top. And we have a range of change ideas that are underway, and we're seeking to embed these national organizational competencies as practice. And we want to unearth best practice to do so. So we're seeking evidence to mainstream these, and this will be evidence within our quarterly reporting in relation to all 3 parts of the PCREF. Next slide, please. So this is a very colourful slide. So it just indicates the 4 cycles, and you've got your 3 outcome areas. So there are some examples under there, such as patient outcomes could include dialogue, service outcomes could be treatment adherence, and implementation could be sustainability. So we went through the governance process that Zoe showed earlier, and agreed on 6 PCREF metrics. 4 of them are included below: service use, access, seclusion and restraint, and use of detention. And there are another 2 in development. So after we do our 4th cycle, we will do a scalability assessment with the successful change ideas, upscale, and then work on embedded into practice. Next slide, please. So here is an overview of all of our change ideas against our borough and service change idea triple leadership teams. And you can also see the boxes with the national organizational competencies that they're aligning with, and also the area of focus. Next slide, please. And now I'm handing you over to my colleague, Annette Davis.
Oh, thank you so much, Shania. My name is Annette Davis. I am a carer. I'm also the chair for the PCREF Service User and Carer Group and Joint Care of the Partnership Group, and also the Communication and Engagement Group. Can I have the next slide, please? Right, so in terms of service user and carer perspective, we're looking at the group agreement, so how it came about and how it's been used. It came about where all 3 constituencies, service users and carers group, community members, and also staff came together to find a method how we would do partnership working. It is used, and it's a 2-page document, which we use in every meeting. However, we can't actually show 2-page document every meeting. So we've summarized it into 5 points. I haven't got a slide for it, but I'll just read them out to you. These are the major points that we use in our group agreement. So the first one is respect and value each other. The second one is working in partnership with understanding. The third one, we are learning together, and learning together means that we can also make mistakes, but we still continue to learn together within the PCREF. The 4th one is empowering the voice of Black and mixed Black people. And one of the ones that I really, really enjoy is the collective accountability for effective PCREF delivery. So that means PCREF is not just based on one person. We all together have to work together in terms of making the PCREF delivery be effective, right? And it's referenced in all our meetings, in our headings as well. Okay, I'll go on to triple leadership. As Zoe and Shania has explained, that we have number 3 to work within the structure of the triple leadership. And how it works well is that we all try and alleviate that power structure, power imbalance. So as myself as the carer service user lead, I am able to share my concerns. The staff will share their concerns, also the community can share their concerns as well. So it's still work in progress, but we're all still trying to work and learn how we can deliver the PCREF for the people that need it the most, which is the service users and carers. Obviously, there's challenges, and I think challenges will come in, but sometimes we forget how emotive this work is. When you're talking about racism, discrimination, it alludes to so many, sometimes trauma, and it's how we support each other and work into making sure that we can deliver on the triple leadership as well. Right, okay, I'll go on to the service user's voice, the differences and the similarities. Now, as we see with PCREF, patients and carers, so that just alludes how important they are. However, it is still important that their voices are heard at every cost. And I feel it's so important to be, as I say, at the table, even at this event here, hearing from different groups how we're working towards PCREF, even though in different areas you may be looking at different perspective. With South London and Moseley, we're looking from the Black experience because the data will tell you that they do not have the best outcomes, and we're trying to really change that. And I'm hoping that with the continuance of PCREF that we'll definitely can do that. So let's move on to, are we rebuilding the trust and confidence for the Black communities, and are we getting it right? I think that is a huge question. I think all of us here, hopefully we're working towards that, but it's important that we see representation. So people that use the service, they can see somebody that looks like them and also willing to engage. And also people that don't look like them, they're willing to learn cultural appropriate theories, services to help so that we can get better experience and outcome for the Black community. And again, it's not even about current, it's about for the future when people use mental health services. I'll just ask a quick question to everybody. If you're working alongside the different trusts, how would you feel if you needed to go in service? Would you be happy to be part of that? So that's how we must definitely continue to work towards improving the access and experience currently for South London, mostly the Black population, but however, in later on, we will look at different groups. So it's not about just ignoring it. We have to accept the difficulties and try and move forward as well. Can I get the next slide, please? Okay, so for further information, just scan the QR code to find out more about our PCREF approach. I know that was a real short, sweet, so thank you very much.
That's all from us. Thank you. Back to the chair.
Thanks so much, and thanks for keeping to time. You're doing my job for me, so I really appreciate that. We've got a couple of minutes now for a Q&A panel discussion. So we've only got, I would say, about 5 or so minutes. We won't be able to go through all the questions that have been asked, but I think it's a really good opportunity to gain perspectives around a couple of key questions maybe. So can I just ask that we've got lots of people on the panel who haven't necessarily spoken and introduced themselves yet. So if you are going to respond to a question, if you could just introduce yourself before you start to speak. So I'm now looking at the Q&A, and also just if again to the panelists, if you spot that there's a question directed towards you or your group, please feel free to type an answer in the chat so we can try and cover as many of the questions as possible. So there's a really nice question here from Afra Kelsel, who's actually one of our MHIN team members, but it's not a plant, but it's a really good question. And I think it's a good way to kind of start off the discussion. So she asks, how do we build trust with communities who've been so badly served and harmed by services so that they help us to improve those same services? And I guess, Annette, you touched on that a little bit just now, but I just want to open that up to others on the panel if they wanted to share a reflection or ideas about this. And if you want to speak, maybe raise your hand or take your camera, put yourself on screen so we can see you. So I don't mean to put you on the spot, but Josephine, I know you've done some really good work in this area. So Josephine is our ED&I lead for MHIN and has done some great work in this area. And I wonder if I could just bring you in on this really important question, because I know you've got a thought or two on this. You're on mute.
I like the way you say you don't want to put me on the spot, but okay. So I was looking at that question because it comes up time and time again about the lack of mistrust. And of course, we shouldn't be surprised about the mistrust because people have been very badly treated. And so I think the issue is that we need not to keep repeating the same old mistakes because it then just keeps compounding the mistrust and the distrust. So I think the PCREF does really present an opportunity to do things differently. And I think there's plenty of data around which shows some of the things that are creating the mistrust, like parachuting in to communities, doing research, you could argue, on Black bodies rather than with Black communities. So that partnership, participatory approach, all that stuff that Jackie outlined, we've got to stop repeating all the same stuff. And I like the question in the chat about does the PCREF stuff apply in research practice? And I have to say that there is such a terrible underrepresentation, particularly of people from Black African, Black Caribbean groups, Black people in research, that we really need to pick that up. And I think we can learn a lot from PCREF and start applying that in research as well, because obviously there's lots of links.
Great, thank you, Josephine. Jackie, I see you've got your hand up. Did you want to come in on that point?
So just on the research point, is that I think that that's absolutely correct, and we have a data and research subgroup that supports the development of the PCREF national level. So very much we are about applying and weaving in the implications for research from the PCREF perspective. So that's that one. I was going to say something else, but it's absolutely drifted out of my head. So I'll just let you crack on.
Okay, thanks, Jackie, for raising that about the group. Does anybody else on the panel have any reflections or thoughts that they'd like to share about that question around how we work with communities? Okay. All right, so I'm going to then, in that case, look for another question. I saw quite a helpful question. So I'm not doing it in any particular order. I'm just finding questions to sort of pick out. I saw a question earlier, and I've lost the question, but it was about work around children and young people. So there we go. So it's a question from Shuo Zhang. Thank you so much for all the speakers for your work. I'm just wondering, how have child and adolescent mental health services been involved and parent services in different localities? Any barriers and enablers, as they may be different than for adult mental health services? So I'm really glad you asked that question, Shuo, because of course we need to be thinking about children and young people, because if we're thinking about prevention, then that's potentially the group that we really need to be addressing. And I can see that, Shani, you've responded, but I wondered if you wanted to speak, say something around that point.
Yeah, it was just to say at South London and Maudsley, our CAMS change ideas fit into each of our 4 boroughs. So we're focusing on improving access rates for children and young people, but also there's that element of trying to build back the bridges that were kind of burnt down in relation to lack of trust by having a campaign where there's co-learning and it's parents, carers, as well as children and young people that are saying, look, this is how I feel. This is what has worked. This is what hasn't worked, to improve staff knowledge and awareness as well as cultural awareness.
And there are, may I just add, and there are some sites across the pilot sites and the early adopter sites that are focused on how to improve children and young people's mental health service provision. And it's, whilst there is CAMS, there's also the whole range of other wider children and young people's mental health services that deal with emotional regulation and so forth and so forth, that actually transcend mental health service provision per se, and actually are located within schools. We have mental health support teams within schools, for example, that are being part of a national trailblazer. What are the implications for improving the racialized experience from that perspective? So when we think about children and young people, we think about their journey that moves beyond just CAM services to from the earliest possible time in their childhood all the way across relevant sectors. So I think that that's really important that we're having that conversation, not just in relation to the children, but children live within the context of parents and families. And what are the implications, therefore, for example, children's social care and how they work. So you can see that actually when you start taking the lens about a race equity accountability of what the PCREF offers, you look at to look for opportunities that we can have a more focused dialogue around improving experience and outcomes for any of the groups, to be that within community mental health or psychological therapies that or children and young people and older people that are in the intersect with and attending to intersectionality, but intersect with beyond secondary care, beyond that crisis sort of like point, is really important if we're to support the movement towards communities, racialized communities where they can thrive and flourish. And I also wanted to just one last point, which is on the what Josephine was saying about researchers representing the demographics of the population. And actually, that's one of the things that made us move to setting up Black Thrive Research Institute and Observatory, because we wanted to really amplify Black-led research to help to sort of like disrupt what is really essentially a very Eurocentric colonial sort of research tradition, and bring those divergent voices to the research agenda so that we can think differently about what's really happening, because we're drawing in different perspectives rather than the traditional one that hasn't actually worked for our diverse communities. So that configuration of a range collaboratively can bring us to different sort of analysis of what's going on, but bring us to different solutions that support the thriving that I've articulated. Thanks.
Great. Thank you. Thanks, Jeff. And thanks for letting us know about this endeavour with research. It's really great to hear. We've got maybe a minute or two, so I'm going to pick up one more question from an anonymous or somebody who hasn't named themselves. A really good question. So they've asked, with PCREF becoming a requirement from April 2024, what can I expect to see being done by the ICB? So I know they're doing something about it. Will there be an ICB board member on the ICB board for PCREF? And will lead names be published? Now, I'm not sure if anybody knows the answer to that. Jackie, you may know how will the ICB board be involved?
In my presentation, that's one of the things that I said, that in our refresh of the PCREF guidance and our advancing mental health equality strategy, we're recognizing that a priority needs to be how do we support ICBs and ICPs to take forward this agenda. If ICBs have this approach of community and working with community and partnerships via the ICP partnerships, then it's intrinsic upon them to be able to articulate and provide evidence about how they are doing that in relation to racialized communities when it comes to mental health. So our expectation would be that they would be able to do that, and we will support them to be able to do that. So we would be expecting evidence of that systems level of responding to your population's health from the racialized communities at ICB, sort of that their attention to that is evident and being really transparent with that. And they also have to reflect their commitment to equalities legislation, their health inequality statement, evidence that the Health and Care Act. All these things mean that from a systems perspective, you need to be more transparent and accountable with one of the worst disparities that we experience here in this country. And the EHRC and the CQC are looking at them systematically as being leaders in this arena.
Right, thank you. Thanks so much. I'm aware of the time. We've got 4 more minutes, and I've been reminded. So I'm just going to draw this event to a close with the last slide. And I've been reminded to ask, which I'll come to. Well, let me just quickly say, let's bring this to an end. Thanks so much to all the people who've presented and spoken and shared insights and, you know, contributed to that very lightning panel discussion. If you'd like to hear more about the MHIN and some of the work we're doing, please complete our feedback forms. You'll receive those and there'll be one in the chat. So please do fill that in, and we will use that as a way to get in touch with you and let you know when we're doing other events or there's anything else relevant that we want to share with you. So just next steps. We've been approved for further funding for another year, which is great news. And so in the next phase, we're going to be focusing on an evaluation of sustainability. So this is something that Scott raised in his presentation. How do we make things sustainable? We're going to be finalising ongoing work. So the projects that you heard today are still happening, and they're going to move towards finalising. And then within the team ourselves, we'd also set up and started to work on a review of approaches to involving racially minoritized people in peer support or advisory roles in secondary mental health services. So this is a review that Jason and I have been leading on with a lived experience, an advisory group that Jason has been helping to convene. And so we hope that this will move forward with this work. We'll be developing resources to catalyse knowledge transfer. So it could be blogs, more webinars, other presentations and so on. So watch this space. And then finally, this is one of 3 projects. So there's going to be a broader cross-network evaluation of implementation. So I think that's a kind of a brief 1-minute summary of where we're going in the next 12 months. I really wanted to just end by thanking everybody who's taken the time to attend today, thanking everyone who's taken the time to present and contribute to the panel discussions, and actually quite a large team have helped to put this event together. So Michelle and Nick from ARC South London, Flavia Bettini, who's our business support manager, who's been amazing, and then a big team of other researchers, Blossom, AfriCouncil, and many others. So I want to thank everybody, and in particular thank everyone who's contributed along the way to this work. This is a consortium of people with lived experience, voluntary organisations, healthcare providers. So we're a sum of our parts. We're here because we come together and we do this work together. So really wanting to thank you all for your various contributions along the way. And I'll just I'll pull Jason in to see if he wants to say a final thank you to everyone.
No, yeah, really thanks for everyone. Go well on your afternoon. It's been a real pleasure to hear about the work today.
Great, thanks so much, everyone. We're finishing 1 minute early, 1 minute to 3. Thanks so much. Goodbye.
Thank you.